So here is a probe. Now, why is high-level disinfection? Endocavity probe is necessary. The disinfected area, the area, as you can see, that would have direct contact with a mucous membrane, for instance, and there's certainly a risk of contamination due to damaged condoms. Condoms often fail, and what's more, as you remove the condom, you might contaminate the underlying probe. The handle is not an area that is often disinfected in chemical disinfection, but there is a risk of contaminating the handle, even though it does not have direct contact with the non-intact skin or the mucous membrane, through contamination of hands or gloves which have touched the patient or have touched the probe that had contact with the mucous membrane. So another question for you. Are you aware of the infection risk when low-level disinfection was used instead of high-level disinfection for disinfection of endocavity ultrasound probes? And I should say by endocavity probes, I just want to be exactly clear. We're talking about probes that would enter, say, the esophagus, such as for transesophageal echocardiography, or enter the vagina or rectum for ultrasound of internal body organs. So again, please select one of the following: yes, no, or not sure, and we'll give you some time to answer that question. Good, excellent. Thank you for sharing your results with us. And I see about roughly 3/4 of you are aware of the infection risk when low-level disinfection is used instead of high-level disinfection, the disinfection of endocavity ultrasound probes. And then about 25% of you are either no or not sure. Again, this is an area that we're going to cover in some detail in just a few moments. So research shows that transvaginal probe contamination, despite probe cover and low-level disinfection. First of all, one should note that 10 to 15% of probe covers will have tears, allowing the entrance of microorganisms from the mucous membrane directly onto the probe. In one study, before disinfection, roughly a third of transvaginal probes had prevalent bacterial contamination after the probe sheath was removed. And again, this can either be through a damaged sheath or by contamination as the sheath is being removed there. 80% of probe handles have residual pathogens, including such pathogens such as MRSA, and even further, more proximal, 62% of transducer cables showed microbial contamination. A meta-analysis found the procedures using low-level disinfection wipes, contamination remained importantly up to 13% for pathogenic bacteria and 1% for pathogenic viruses on endocavity probes. And this is because obviously when you use a probe wipe, you need to have contact of the wipe for a sufficient time of every single surface. So if there is either insufficient time, improper use of the wipe, meaning it already had dried out, or you missed a little piece of the probe, then you end up with residual contamination. And there are many studies out there showing that despite probe covers and low-level disinfection, pathogens remain on the probe. Of particular importance, of course, is HPV, human papillomavirus, and you can see here studies from Hong Kong, France, Spain, and another study from France showing that these probes, when tested after use, anywhere from about 3% to as high as 15% were positive for HPV as measured by looking at genetic material. The study highlights low-level disinfection to be insufficient. A retrospective study from 2010 to 2016 revealed an increase in infection risk in the 30 days following transvaginal ultrasound. These patients were found to be at roughly 40% greater risk and a 26% greater risk of needing an antibiotic prescription in the 30 days following their transvaginal ultrasound. So we've noted here that this is quite important. So it's not just a laboratory finding that these probes might have, and certainly do have, pathogenic bacteria or viruses after use in a patient with probe covers and low-level disinfection. But clinically, there is a substantial risk to the patient of acquiring an infectious disease requiring therapy. Now, again, infection risks of low-level disinfection of endocavity probes. This was a computer model. The goal was to assess risk for transmission of infection via endorectal or vaginal ultrasound probes using probe covers and low-level disinfection in France. I was a co-author of this study. Method was a stochastic Monte Carlo simulation. The results showed over France there'd be 40 new HIV infections. For other viral diseases, a range of somewhere between about 1,500 and 15,000 other viral diseases. And the conclusion is one must adhere to the guidelines from the Centers for Disease Control for the use of high-level disinfection, which, as we've already seen, are really the standard from across the world. On the right, you can see an actual reproduction of a table from that paper, and you can read that in detail. The references are all listed for you at the end of this presentation. But you can see the risks include HIV, hepatitis B, hepatitis C, human herpes simplex virus 2, HPV, importantly, the most difficult to inactivate, CMV, and chlamydia trachomatis. So a variety of viral and bacterial pathogens that would remain on a used probe that could infect the other patient, and as you've seen in this modeling study, lead to a substantial number of infections in a country about the size of France. So if you think compliance is expensive, certainly try non-compliance. This from a U.S. Deputy Attorney General there. So in the United States, failure to perform correct disinfection certainly has led to a substantial legal risks, expensive lawsuits filed against hospitals as well as individual practitioners for improper probe disinfection and putting patients at risk, as well as another case of patients possibly exposed to sexually transmitted diseases. So this is why disinfection of endocavity ultrasound probes is necessary. This is a general statement not specific to infection prevention, but to all diseases, in fact. Prevention is better than treatment, trying to cure a patient afterwards. I should say, by the way, prevention is always better in life, such as wearing seatbelts as another example. Always better to prevent injury than deal with the consequences afterwards. Healthcare facilities that follow evidence-based guidelines for disinfection of ultrasound probes can allow the key issue. We all want to protect our patients, and that's what high-level disinfection allows. We decrease contamination, and we decrease healthcare-associated infections. Up to 70% of healthcare-associated infections are preventable using existing infection prevention practices detailed in the guidelines that we already mentioned. Now, in terms of devices, infection transmission occurs due to really three things. Inadequate cleaning. Cleaning, and I'll say this again, cleaning must precede disinfection. Cleaning removes 2 to 4 logs of organisms. Improper selection and use of a disinfecting agent. Whatever method you use for disinfection, you need to follow the manufacturer's instructions and follow them rigorously. So for a chemical disinfection, you obviously need the proper concentration, proper use, and safety. And then failure to follow recommended cleaning and disinfection practices and procedures. Focus on guidelines on high-level disinfection endocavity probes classified as semi-critical, again, with 3 steps to reduce the contamination risk. Thorough cleaning after each use, particularly if you're using, of course, ultrasound gel, those must be carefully removed. Then, following appropriate and thorough cleaning, high-level disinfection. And again, for added safety, the device should be covered with a single-use probe cover before the next patient examination there. And reference guide to cleaning ultrasound transducers in obstetrics and gynecology. So again, for a transvaginal probe, for instance, you want to use a cover and high-level disinfection. For external probes, if it's intact skin, you really don't need a transducer cover, but it's always good and safe to use one and low-level disinfection. If you're using the probe on non-intact skin, such as a burn patient, you should be using a transducer cover and high-level disinfection. If you're using amniocentesis or suprapubic bladder tap, again, you can use a transducer cover and high-level disinfection. So, next question. Does your facility complete all three steps? First, clean. Second, disinfect. And 3, use a probe cover before using, well, after using a transvaginal probe on a patient before using it on the next patient. Please select between yes, no, and not sure. And again, I can see that 80% of you are in fact following the guidelines and recommendations from international organizations that we just mentioned. 7% of you say no, and 13% are not sure. Again, we'll be discussing this in more detail in a few moments. So let me explain again. Another way of looking at it is this so-called, we'll go back down. This is called the Swiss cheese model of medical errors. And of course, as you know, in Swiss cheese, there are various holes in the cheese. In order to have a medical error in general, you have to have something that lines up with each hole, and you can prevent it by using various steps along the way. So you can see here cleaning, which actually removes 2 to 4 logs of organisms. We've shown this with my colleague Bill Rotella repeatedly in lab-controlled experiments and in real life. Then you use a second method after cleaning of disinfection, which achieves a 4 to 6 log reduction, high-level disinfection here for ultraviolet light, a 5 log reduction. And then by adding a probe cover before you use it on the next patient, you get a 2 log reduction of contamination of the probe. Again, not complete safety, but some reduction. So if you add all of those up, you end up with your total log reductions here, which is, you can see, would be for this model, would be 9 log reduction, which is substantially higher than any possible contamination on a probe. And here we're talking specifically about HPV. Again, 3 steps to reduce contamination risk. UVC radiation is an effective disinfection method to inactivate human papillomavirus there. So it's really UVC irradiation, and you can see here that as with actually all microbes, they are all susceptible to UVC, although it depends on duration and energy levels for how long it requires to disinfect some different microbes there. As we've noted earlier, HPV will be more difficult to kill than an enveloped virus, but you can see here that UVC radiation is very, very successful. And here they were using the automated antidermics there, and this device showed efficacy against the HPV 16 and 18 types. These are 2 of the most crucial types, most frequent as well, because these are the types of HPV associated with cervical and vaginal cancer. Notice that OPA in these studies showed minimal efficacy. So these results from this study suggested that healthcare facilities using endocavity ultrasound probes need to strongly consider disinfection methods that have been demonstrated to be effective against HPV. Again, 3 steps to reduce contamination risk. You can see, of course, on the left, 0 logs give you no % reduction. Once you get into the green, 7 to 9 logs, you're talking about tremendous reductions there of 99.9999% inactivation there. And so if you started with 1 million HPV, by the time you reach 7 logs, you've completely eliminated all the HPV. And then you can see here what type of kill levels you get with low-level disinfection plus a commercial cover, condom cover, compared to UVC plus commercial cover or a condom cover, and the enormous log reductions and safety factors that you have with use of a method such as ultraviolet light compared to low-level disinfection. Keep in mind that, of course, patients who would be infected with HPV, you're almost certainly never going to know about. This is a hidden epidemic because they won't be picked up for months or years until somebody does a test for HPV, or they would develop a cancer that was HPV related. Again, steps to reduce contamination for HPV, cleaning, low-level disinfection, and probe cover. You can see here that you have only 99.9% removal at best. And so if you have enough patients, clearly there are going to be patients in whom this method will lead to contamination and infection. Whereas on the right, if you use a high-level disinfection, such as with ultraviolet light, you're adding cleaning 2 logs, which is really 2 to 4 logs in many cases, disinfection 5 to 7 logs, and then additional protection with a probe cover, which really gives you a 0 risk for the patient. Now, JCI reinforces prevention and control of infection in their latest standard review. JCI is the Joint Commission International, which does accredit, JCI in the US accredits hospitals for billing from the federal government in the United States, but as well they have an international accreditation association as well, just as a way of demonstrating hospitals are following guidelines, not only in infection prevention, but all standards related to improving patient safety and improving patient care. So the Joint Commission prevents control of infections here under the guideline. Procedures that involve contact of medical surgical equipment, devices, and supplies can be introducing pathogens and lead to infection. They note failure to properly clean, disinfect, or sterilize and store the devices not only poses a risk to patient, but carries a risk of person-to-person transmission. And it's crucial that healthcare personnel follow standard practices for disinfection and sterilization, which include proper cleaning and then appropriate disinfection and sterilization per the Spaulding classification. They then go on to give you a number of guidelines there that they follow the manufacturer's guideline for low-level and high-level disinfection, and follow professional guidelines, which I've already mentioned, for a device that touches the mucous membrane, require high-level disinfection there. Also, that you follow appropriate methods for cleaning, disinfection, and sterilization, and these are coordinated and uniformly applied throughout the hospital. And then once the device is cleaned or disinfected, it should be properly stored in an area that's clean and dry, protected from dust, moisture, and temperature extremes. Again, they say hospitals reduce the risk of infectious diseases with medical and surgical equipment. The intent revised to recommend that hospital use the Spaulding classification system to determine the appropriate level of disinfection or sterilization for each medical device. And they added the information on the expectation of hospital leaders. So it's incumbent for individual practitioners as well as hospital leaders to follow these standard recommendations. When to consider and selecting a high-level disinfection system for ultrasound probes, 4 key considerations. First, workflow. To meet clinical workflow requirements, medical staff need to consider the turnaround time between patients. Obviously, the shorter turnaround time that provides appropriate disinfection maximizes patient throughput. Traceability, you certainly want to keep records of high-level disinfection, making sure that the disinfection occurred properly and the system worked. Automation certainly provides benefits over manual disinfection, as opposed to, say, dipping a probe into a liquid chemical that include reproducibility and a consistent disinfection process between operators. It reduces staff error, and very important, does not expose, if you're using UVC, does not provide any exposure to chemical fumes, and therefore maintains and assures safety of the healthcare personnel. And then validation, automated verification system monitors that monitor critical process parameters in real time. And with the use of the UVC device, you're getting monitoring continuously of UVC irradiation on the device, making sure that you're getting proper high-level disinfection. And this is harder to achieve with a manual system. So in conclusion, the evidence-based research is a major driver in changing clinical practice, establishing new guidelines, and clinics adopting new technologies such as UVC high-level disinfection. Published research papers show ultrasound probes are a potential source of infectious transmission, posing a new challenge for infection prevention. Not all research is of sufficient quality to inform clinical decision-making. Therefore, you need to critically assess the evidence before you use it, not only for ultrasound probes, but for everything you do in medicine. Comparing low-level disinfection practice to high-level disinfection process and reproduce and reprocessing ultrasound probes, of course, the subject of our talk. And I've shown you the evidence as well as the guidelines, which are certainly appropriate and provide a solid rationale for why high-level disinfection should be used over low-level disinfection. Ultimately, it all comes down to high-level disinfection ensures patient safety, and certainly use of the ultraviolet C device it makes things easier, as well as protecting your healthcare personnel. So, 3 major aspects of evidence you need to critically evaluate. Validity, can you trust it? For low-level disinfection, only a 4-log reduction. Impact, are the results I've shown you in the research clinically important? I hope I've convinced you that use of low-level disinfection places your patients at risk for acquisition of an infectious agent that was present in a previously studied patient, and the contamination of the probe occurred and remained on the probe despite low-level disinfection. Not only potentially, but actually that could lead to infection of the next patient. And applicability, can you apply this to your patients? So we have finished our lecture part of why high-level disinfection is necessary for endocavity ultrasound probes. I'm happy now over the rest of the time for this presentation to answer any of your specific questions that you might have.
Wonderful. Thank you so much, Dr. Weber. And we're obviously going to be taking questions now. So if you haven't done so already, go ahead and type any questions that you have into the questions box in your control panel, but we do have some questions coming in. Okay. The first question, if the probe cover does not tear, do I still need to disinfect the probe before the next patient?
The answer to that question, it's an excellent question, is yes, for several reasons. One, multiple studies have shown that probe covers may fail, have inapparent, and I want to say that again, they may have holes or leaks you're not aware of. The way those studies are done looking at probe covers, there are a variety of techniques one can use. One would be if it's something like a condom cover, is just take it off. You can fill it with water, look for small leaks. If it's a more solid material, you can use various methods such as filling the probe cover with electrolyzed water and then using technology looking for ions and others. So probe covers, even though they're not visibly leaking and have holes in them, often will tear or leak. That's the first issue. The second is it is almost impossible to physically remove a probe cover by pulling it off and have 100% assurity you're not contaminating the underlying probe. So if you have even gloved hands and you accidentally touch the probe cover to the probe as it's being removed, or your hands which have touched the probe or have touched the patient's mucous membranes now touch the probe, then you will contaminate it. And again, that's not visible. So one, the probe covers, and I've shown you the evidence, often fail. And two, then when you look at the underlying probe, despite the probe cover, you will find in a substantial number of cases, meaning 15 to 50%, very high numbers, you will find microbes on that probe that clearly are patient-related, not environmental related. And by that, I mean you're finding things such as HPV, Staph aureus, E. coli, Klebsiella, not a simple skin flora that might be in the air, such as coagulase negative staphylococci or other relatively non-virulent organisms. So again, probe covers can never be used with the surety of maintaining the underlying probe pathogen-free. And again, that's why the recommendation is first, thorough cleaning, in part to remove the gel that might be on the probe, but to remove a substantial number of the organisms, and then followed by high-level disinfection, which is giving you 4 to 6 logs of additional removal of organisms. But again, the probe cover does help prevent high-level contamination, and I certainly recommend its use. Again, we want to use a system that is most protective for patients. Thank you.
Great, thank you. Next question. My manager recently implemented a new automated disinfection system, not just because it was quicker, but rigorously tested against HPV. What evidence do you need to prove a system has been tested against HPV?
That is really an excellent question. So there are several ways to test against HPV. HPV is very difficult to culture. So the most common way of testing is to actually look for HPV DNA, which can be done. And certainly if there's no DNA on the device after cleaning and disinfection, then you have eliminated all the HPV. However, if you do find HPV DNA, it doesn't necessarily mean it's viable HPV, in which case you would have to use a culture technique to find the HPV, which is difficult, but there have been published techniques there. And I should say, when one looks at using some of those HPV culture techniques, there is a literature that suggests that some standard high-level disinfecting chemical agents may be unable to inactivate HPV. So that is an ongoing area of research and concern. The Centers for Disease Control has not specifically stated that agents which have been approved in the United States by the FDA for high-level disinfection, that you need to select agents specifically that studies have shown that inactivate HPV yet. But it is a major concern that there are some studies showing that some of the FDA-approved high-level disinfectants may not completely inactivate HPV. And as I've noted already, UVC light will, with sufficient time and energy, which is built into the UVC device we've discussed, will completely inactivate HPV, as they will inactivate all other microorganisms, although they will not necessarily inactivate 100% of the spores at the time that's being used on these devices. Thank you.
Great. All right, next question. If I clean an HLD And if I clean an HLD the probe and achieve over a 6.5 log reduction, why do I need a probe cover? I get a better image clarity without it, and it would save time.
Again, it's if you're using cleaning and appropriate disinfection, you are over 10 to the sixth, and therefore you would meet the guidelines for a high-level disinfection and would not need a probe cover. Again, it's just the professional groups making recommendations, just wanting to have multiple layers of safety so that if in the chance one of your technologists, technicians, or nurses did not adequately clean the object, and therefore now you're only using the high-level disinfection, the probe cover is giving you added protection. It's much like in the same reason in the United States, we build cars that have seat belts, then they have airbags, and then the car itself is built to, in a high-speed collision, to sort of crumple properly to protect the passengers, because we want redundancy in our system so that if one system doesn't work, for instance, somebody didn't buckle their seatbelt or the airbag failed, you have other systems to protect you. And the same thing is true in medicine. We are risk averse, and we like to build in systems that help prevent any possibility of errors if there is an error in the processing such that one part of the processing is not done correctly. It's the same reason in the United States, for instance, when we do a blood transfusion, a high risk of substantial patient harm if someone gets the transfused blood that's improperly cross-matched. So in the United States, we have a double check system where two nurses separately have to independently verify that the blood that was sent to the patient is in fact the correct blood type of the patient before it's administered. Just a way of assuring additional assurance of patient safety. And we build this into many things that we do. You know, when we have a patient with MRSA in the United States or another multi-drug resistant organism, all our healthcare personnel in the room will wear gloves. You could argue that if a healthcare personnel performed hand hygiene with soap and water or an alcohol disinfectant and the patient had MRSA, 100% of the time, if they followed hand hygiene, they wouldn't need to wear gloves. We wear gloves to add in that extra burden, extra level of safety, because we know healthcare providers sometimes forget to wash their hands, and so we want redundancy in the system. And that's why we recommend probe covers. Thank you.
Next question, do you have thoughts on the use of wipes for HLD?
So the concern about wipes for HLD as opposed to another method such as UVC are a number. I've already talked about the fact of redundancy. Here I'll also mention that to the extent possible in medicine, we've always found re-engineering a system is better than trying to educate individuals on how to do something properly. That's why when you look at, say, an automatic endoscope reprocessor for such as an ERCP scope that automatically cleans and disinfects a ERCP or a duodenoscope, you find lower risks for contamination, as opposed to having a human do all the manual cleaning and the manual chemical disinfection. If they did the cleaning and disinfection 100% of the time, it would work. So the problem with the chemical wipes, the chemical is certainly active if it's a high-level chemical against the pathogens we've mentioned. But the wipe has to be used properly, first of all, meaning it can't be dried out, it can't be past its storage time there. Depending upon the size of the device, like let's say you were using a transesophageal probe, or you have a very long device, you may need to use more than one wipe to cover it there. And most importantly, the chemical must have contact with the pathogen for the correct time period to inactivate it. So you take your chemical wipe and you wipe the probe And ideally, you would also wipe the handle where your hand was, as I've already mentioned that was contaminated. You have to make sure you've touched every single part of the probe. This is, can be difficult because the chemicals are generally clear. You can't see what part of the probe you've touched. You can't really see whether you've missed anything. So yes, when done perfectly properly, you would get 100% safety, but it's very hard to assure all of those other factors, and it's much easier to use a system such as a UVC, where you put the device into the machine, you close it, you push a button, and you're assured completely that every part of the probe was reached by the UV light and disinfected. So again, we've engineered here a system that reduces and eliminates any possibility of a human error in not touching every part of the probe with the correct concentration and proper use of the wipe. Thank you.
Okay, next question. What is the correct method to clean and wipe the probe? Any specific way of cleaning?
So here I cannot give you absolutely a specific guidance on cleaning. I'll give you some general guidance. So you need to look at, for your high-level disinfection method and the exact probe, what the manufacturers recommend for the cleaning method. That is, what type of specific wipe they use, or is it an immersion into water, or is it put into running water? So I can't give you a specific cleaning method. What I can tell you is whatever cleaning method you do use, of course, you want to remove any gel that might be on the probe, any visible contamination, so anything that you visually see, meaning mucus, any dried blood, serum on the probe, any discolored areas, all of those should be cleaned, and so the probe should look as completely clean as possible, as essentially look just like when you purchased it new. And you need to follow the manufacturer's recommendations, both for the disinfection method and the probe, to do that cleaning properly there. Now, I should tell you the difference between cleaning and disinfection, just to be clear here. Cleaning is the physical removal of grime, dirt, and microbes, gels, other things that would interfere with the disinfection method. But it doesn't remove microbes completely, so it does remove a few logs of them, but there are clearly going to be residual microbes left after cleaning. Disinfection then is a chemical or another means. In this case, we've talked about UVC light irradiation for actually killing microbes. So that's the difference between cleaning and disinfection. They're synergistic and additive. They should always be used together to achieve the maximum removal of microbes in order to protect your patients. And this is not specific to endocavity probes, but it's critical for surface disinfection of room surfaces in hospitals, as well as instruments that would be used for surgery. Cleaning always precedes disinfection and sterilization of any reused object. Now, of course, if it's a single-use object, after it had contact with the patient, you're throwing it away, then it needs neither cleaning nor disinfection. You would just discard it, and you need to just make sure it's not improperly reused if it's labeled as a single-use object there. An example of that would be, say, a single-use plastic specular for doing a vaginal examination. After it's used, you would just discard it. Thank you for that question.
Great. Next question. Well, thank you, Dr. Weber, for the wonderful talk. And her question is, do cancer patients have a higher risk of being infected by HPV from a dirty probe compared to normal patients?
So that's a very good question. I'm not aware of good studies on that. Certainly, patients who had damaged mucosa that would allow easier entry of HPV, inflamed or damaged mucosa, would be at higher risk. But likely, patients who have compromised T cell immunity or antibodies would be infected potentially with a lower dose of HPV than somebody with a healthy rectum or vagina. So the answer undoubtedly is yes, they will be at greater risk of being exposed to HPV, of infection, although I'm not aware of a specific study that's really looked at that risk carefully. But based on everything else we know about acquisition of infections in patients who are immunocompromised that are occurring via the mucous membrane, an example, of course, is SARS-CoV-2, except it's the respiratory system. It's here. If you're immunocompromised, you're one, at greater risk of infection, and two, if infected, you're clearly at greater risk of consequences of that infection. So, as you know, it's well known that if you have infection with HIV and then you become infected with HPV, your risk of then developing an HPV-related cancer is certainly much higher, as it is for other infectious agents that would be acquired via mucous membranes, such as cytomegalovirus or Epstein-Barr virus as well. Thank you. Very good question.
Okay, and I think we're on to our last question here. For FNA cases like FNA of thyroid nodule, do we need to have HLD of the probe also?
So if you're using the probe on intact skin, such as for, as you said, a biopsy of a thyroid nodule, or an amniocentesis, or for putting in an intravascular line, we widely use these for putting in subclavian lines. The answer in the United States, again, cleaning and low-level disinfection are considered adequate. If you choose, you can certainly do high-level disinfection. Again, the guidelines only set a minimal disinfection standard, but unless the probe was grossly contaminated with blood, the answer is no. And here, low-level disinfection is adequate. And the fact that there might be some minimal blood on the probe, low-level disinfection is what is recommended in the United States for those endocavity probes used on external surfaces. Again, there's no reason you can't perform high-level disinfection, but that is not part of the U.S. Standards. Thank you for that final question.
Great. And before we wrap up, did you have any final thoughts you'd like to share?
Yes, thank you very much. First of all, I want to thank you all for participating in this talk and for your excellent questions. I know everybody is always busy, so I appreciate your time. And I just want to make the final point again that proper cleaning, high-level disinfection, and proper use of ultrasound probes, as we've mentioned, protects your patients from developing healthcare-associated infections. And certainly, the first rule of medicine is do no harm. We certainly want to use the probes correctly, which we do, to improve patient care using them diagnostically. But we certainly want to protect our patients at the same time. And as I've laid out, that can be done in a relatively straightforward method. Again, thank you for your time. This will be followed, by the way, by a survey at the end that we hope you will all complete.
Thank you so very much, Dr. Weber, for your presentation and for taking the time to answer the questions. And we also thank our audience for attending. And on behalf of Dermatech, Delta Medicines, and Connet, who sponsored the webinar, we would like to thank you for taking the time to join again. And at the end of the session, as Dr. Weber just mentioned, please complete the quiz so a certificate of attendance can be sent to you. Please enjoy the rest of your day.